So good morning, all of you. Extremely happy to be here, and I thank Jom, Arun, and the team of Hospex to invite me for this particular talk. And I'm extremely happy to deliver this talk again in front of my great teachers, great physicians, and along with quite expertised critical care specialist in Dilip and the rest of the stuff. At the outset, I would like to say that I'm entirely going to talk in terms of a surgeon's perspective. And I'm carrying my impressions and my viewpoint on postoperative pyrexia based on my experience of the last 24 years and heading surgical oncology and oncology for the last 7.5 years. So that is my base of this particular talk. And I carry regards from Government Medical College Thrissur as well as the Department of Surgical Oncology and General Surgery. So at the outset, I would like to quote great William Osler, who quoted about the seriousness of fever in medicine. But as a surgeon, I would like to modify what great William Osler said. I always consider when a patient spikes on the postoperative side as a lead point to investigate on and to look for what is causing this particular sort of a fever. It's actually a guide for me to reduce the morbidity, or it's a leading light for me to take it further to identify what exactly is happening with the patient. So basically, the slide, I'm sorry I'm projecting in front of such a senior faculties, but I always tell my residents that whatever be the problem, your approach is quite vital. And this stands so solely good in a postoperative patient, because you're putting a knife on a patient which walked into your office with a problem and probably with a normal physical stature, and you have touched the patient with your knife, and it is mandatory that you have to probe well to get into the diagnostic algorithm and get the management option sorted out. So, when we talk about the postoperative pyrexia, it is not so uncommon in postoperative patients, as we all know. And it varies from around 20 to 90% in various studies. Only thing is, when is this pyrexia and what is the presentations like, how it is presenting, for a surgeon to go further into that. So, approach to postoperative fever basically starts from me as a surgeon who has interfered on a patient on something probably cynical with a malignancy or with a benign condition, and there starts my worry about that particular patient. So when you have a patient with a postoperative fever, there are three thoughts which will come into my mind. Possibly, is it a physiological response? That is the first thing. Second is it an accelerated physiological response the patient is having? And the third is the patient going to a sepsis or organ dysfunction? The demarcations are very minimal, because when we see the physiological response, like in any trauma, any patients who underwent a surgical trauma will have a physiological response with the liberation of inflammatory mediators. And various people are probed into how far it can occur, how intense can occur, and what are the markers which will come up. And IL-6 and the correlation of IL-6 with the response, the inflammatory response, is the best correlation that can have. That is, the amount of IL-6 rise also correlate with the timing of surgery. Because we have found that, our studies have found that the level of the IL-6 starts to go up from the 0 hour after your insult, and probably by 7 to 11 hours, it peaks. So an inflammatory response which occurs as a physiological response peaks around the 11 hours of the surgical trauma. And it varies with the amount of the surgical insult you are causing, or the amount of the difficult surgeries you do, or the timing you take up for surgery. And basically, I as a surgeon is not concerned if it's a single spike of a fever. But I am worried when my patient spikes in different patterns. if it's a sustained fever, whether when it is an intermittent fever, when it is not remitting and it is a sustaining, or when it is a high-grade fever. That is a point when I am worried that whether my patient is going from a simple inflammatory response to SIRS and then going for organ dysfunction. And that is a point in which I don't want my patient to go. I don't want the second hits to hit on the patient where I've already done 6 or 7 hours of procedures. I'll show some examples where patients can go wrong. So it is customary on my part to have certain things to look upon when I walk into a post-operative patient, or when my residents call me, because I operated yesterday and we had an esophagectomy, a right hemicolectomy, and these patients on today morning rounds, I'm here, and I want my residents or my trainees or senior residents to call me and tell what is happening. And what I am bothered is, my mind goes in a fashion when they say there is a patient spiking, is it something to bother? That is the first thing that goes into my mind as a surgeon. So I'm not a critical care expert, but that is, as a simple terms, I will think in terms of, is it something to bother? Second thing I will think is it an inflammatory response? Or is there some sort of an infection that is popping up in the patient, not on the day one preferably, or is it endangering the patient? Because I can't afford to lose a patient on the next day just because patient had something which I could have prevented. And my actions are just like a Formula 1 pit stop. My actions should be a Formula like pit stop. That is the word I use to my interns and residents and surgical onco trainees, that you need to act just like what is done in Formula 1 pit stop. Your action should be second-based. Your action should be minute-based. You cannot wait for the next day. You start acting then and there. Because you can't wait for an hour. You can't wait for 1 day to start acting. So your action as a surgeon, because I am responsible for the insult that I cause to the patient in terms of the surgical insult. So when you probe the surgical post-operative fever, most of the fevers are usually late in onset. I'm not worried about that. Not that I'm not worried, but I will be able to find out what is causing that fever. Because as the days goes on, the ability to diagnose this problem is quite easy, because they come up, because 30 to 70% of the fevers occurring between 3rd to 7 days are picked up fast on your serial investigation. But about only 20%, 1 in 5 of the fever causes are identified when they spike on the day 1 and 2, and most of them are benign. Okay, 80% of them are due to benign causes which will end up on their own, but 20% will have some serious problem, which if you miss, you lose the patient. I'll come to that, what are the things which I as a surgeon will look upon. And as the days goes on, again, there are various causes which we are all aware, and Dilip also highlighted on the most of the important causes. I'm not going to that again, but I will still feel the condition as a surgeon, I will be keen to look for. My medical colleagues are here, and they always support us with the thought process which we never think about. My critical care team of anesthetic team usually comes up with some ideas which sometimes will be very helpful. But me as a surgeon has got a big role in telling them what I am worried about in this particular patient. As a student, as a trainee, as an initial physician, initial surgeon, we have been told on the post-operative day with the Ws, the 5 Ws, the 7 Ws, and all. Those are the reasons why, and the timelines by which you can identify the fever. But my experience over the time period of 30 years is that these times are just an overall idea for you to look for, and this can overlap to a great extent. Because if you say that on the day 1 it is atelectasis and pneumonia, or atelectasis, I don't think all atelectasis spikes. All patients with atelectasis spikes, but it is customary for you to have a look into these patients to see whether it is basically due to atelectasis. So the timelines are very important. Now, in front of this audience, I just, with an august audience of physicians and critical care specialists, I want to introduce a term, or I introduce this term because I call it as a 0-hour pyrexia, just against with a timeline. Because Zero-hour pyrexia, what is meant by few surgeons on the Royal College of Surgeons is a patient whom you do a procedure of 7 or 8 hours. I work with 2 surgical oncologists and 3 surgeons in my unit for the last 7.5 years, and some procedures goes on for 8 to 9 hours. And these patient goes to the intensive care unit, on the post-operative intensive care unit, and the resident calls up midnight and saying, sir, this patient has got 101 temperature. What should we do? So, should I be worried? Should I be not? Should I say, okay, forget about it, we will wait till tomorrow morning to have a look? That is what I call, or we call it as a zero-hour pyrexia. So, I'll just take a clinical scenario. Sorry, the video, I don't know whether it will be working. This gentleman was operated last Thursday, and I think that he's going to be discharged day after tomorrow. And he had a globus tumor of the stomach, which I scoped, and he was bleeding. His blood levels are coming down. So we took him up, we scoped on Tuesday, we took him up on the Thursday to do a sleeve gastrectomy. And we did a sleeve gastrectomy on Thursday. Operating time was only 1 hour, 2 minutes or 72 minutes because it was a laparoscopic sleeve gastrectomy. Without any difficulty, the patient was extubated and moved into the surgical ICU. But the call I got at night around 9 o'clock by one of the senior residents was, sir, the patient is spiking. Patient is spiking temperature. I was damn sure there is nothing from my part to cause this fever. So, but I was worried, why this patient spiked, which I never expected him to spike. I thought everything was going smoothly. This is actually the 4th glomus tumor we going to report from our institution. It's a rare tumor, but again, the procedure-wise, there is nothing dramatic. It's a simple procedure. Some of the surgeons are there. The sleeve gastrectomy is not a big procedure to be worried about. But definitely, I was worried why this patient is spiking. On the same day, my colleague Dr. Sharad did a total parotidectomy for a mucoepidermoid carcinoma. Took 5.5 hours, and this patient was in the post-operative ward. She also had a mild spike of fever. Again, I was not much bothered about that lady, but I was bothered about that gentleman because he had something which is missing from my head. Right. So when a patient spikes on the early postoperative fever, even though 80% are benign, I think that is where, as a surgeon, I am worried. Because it can be due to various causes which, as a surgeon, we may miss. One is myonecrosis, but that is not applicable to him because the operating time was only 1 hour, 2 minutes. We don't expect it to happen in a procedure which we did for only 1 to 1 or 1.5 hours. I'm not worried at all. But looking at the next cause, the pulmonary embolism, the question I asked my resident was, what is the saturation? What is this vitals? And she said that it dropped from 94 to 87. So I had a thought process that is it PE? So I said investigate on the PE line, and then put him on 4 liters oxygen, and then she said it improved back to 94. So that was initially sorted out, but we went on investigating on the PE line. Next was alcohol withdrawal. I would rather say that this is one thing which we normally, I'm not saying all causes of postoperative pyrexia is due to alcohol withdrawal, no, but you have to think about this entity also when they spike in the immediate post-op, because they suddenly moved from that dependence to a non-alcoholic environment. Possibly that was one cause in my mind. The 4th cause which I highlighted is the bowel disruptions. Surgeon sitting there, Sajit is there, Kiran is there. Surgeon sitting there is aware. That is, when we do colorectal surgeries, especially we are sitting in a medical technology consortium conference where we use a lot of gadgets for anastomosis. And these gadgets, especially when we do it for esophagus and for rectum, I have seen total anastomotic failure which occurs on the day 1. And these anastomotic failures, because of the gadget issues, will be, for a surgeon, it will be very difficult to accept the fact that your anastomosis misfired. But when the patient immediately spikes in such a scenario, please, I will always think about that entity also. And as a critical care specialist, you should also be asking the surgeon, Even though the signs and symptoms will be not so predominant, that is one possibility patient can spike, in addition to the other causes of adrenal, endocrine causes and malignant hypothermia. But again, the possibility of PE and alcohol withdrawal should be definitely thought about in this context. I'm taking another case into this condition where we had a mucinous adenoma of the pancreas, a young lady, 34-year-old lady, and she started spiking on probably on around 36 hours after the Whipple procedure. And that lady was 34. She had a major procedure standing for around 7 hours, including intubation to extubation. And she was on ventilator on that day. We extubated the next day morning, but she started spiking. So again, that is a concern. We cannot sit idle to say that, no, don't worry, it will be fine. It is 20% benign causes. And luckily, we could identify that she had a PE, and the treatment could be directed towards that. These are some examples which I would like to quote in this regard, especially with the first day. Now, I am not going to the details of atelectasis and the fever, the patient presenting with fever. I know there are experts who can comment on that more than me in this forum. And I would like to say that from a surgical perspective, I feel that atelectasis need to be looked for any patient who spikes. But atelectasis and the causation and the fever doesn't sometimes carry a definite correlation. This is what I tell my residents, that atelectasis, around 25% of patients with atelectasis will not have fever, and as the days goes on, atelectasis progresses, the fever will start to dip down also. So lack of fever doesn't mean that patient have atelectasis. I always say, when you do major surgeries, upper abdominal surgeries, major colorectal procedures, whenever you touch your thorax, think about atelectasis and try to take preventive measures to counter it. So basically, that is the approach which I normally advocate in case of a initial days fever. But as the day moves on, this is from post-operative day 3. I'm just going to take this as a together when that is a delayed fever, which as a surgeon, after 1, 2, or 3 days, you are a little bit happy that the patient is settling down. And this gentleman is still in ICU. They operated on the last Thursday. Today is the 3rd post-operative day. And he had mild fever yesterday. No, I think this was actually the previous patient. He was operated 2 weeks back on the last week of July. And this gentleman had a mild fever. And what turned out to be, he was on ventilator for 3 days. And this was definitely, the reason was pulmonary. So delayed fever, we will have obvious reasons being identified, and it is almost 80%, almost 70 to 80% on studies also. We could identify what is the source of cause of fever, and we can direct our treatment towards that. But early fevers is what is confusing me all the time, and that is what it says also. Because infectious fevers, which occurs within 72 hours when you tackle an infectious cause like a peritonitis, biliary sepsis, you operate and patient gets a fever, you are okay with it, you know what it is causing, you can direct your treatment. It can also be fevers developing or persisting after 72 hours. You need to probe into conditions or regions where it is likelihood of infectious cause. So, what are the causes which we should think about on the infectious side? First and foremost, we will say the surgical site infections, which I will come to that later. Then comes, Dilip had already highlighted on the 2 entities of urinary sepsis and catheter-related sepsis. So I don't think I'm an expert to comment more on that than him in this particular forum. But definitely, as a surgeon's perspective, I will share some points which I would like to add on. I'm worried when my patient stays on ventilator, when I do either Whipple or whether I do a hernia procedure, whether which is done as a laparoscopic cholecystectomy, whether we did a laparoscopic or thoracoscopic esophagectomy or a 3-stage esophagectomy. I am worried when my patient stays on ventilator for more than 2 days. I want them to be out of ventilator as early as possible. because more time they spend on ventilator, definitely the outcome is they're likely to have a nosocomial pneumonic infections, and then that is one worrisome thing, because that is something which as a surgeon I can't do anything. I can just watch, I can just take help from my multidisciplinary team and get it on, because it's something beyond me. And again, I have 3 advices again I will normally tell. Less time on ventilator. If you are keeping on ventilator, reduce the dead volume, get a tracheostomy done, change into ventilator, early bronchial toilets, early bronchoscopic interventions, which has got good results. And I happen to gain, as Purushothaman sir said, I happen to gain from few words from Dilip just a while ago about the tracheal cultures are important. I also used to get biased, Dilip, when they say tracheal cultures have grown up this thing, and I immediately say change the antibiotic. And this is a good point you mentioned in the talk. So that is what I would rather likely to do. Then coming to catheter-related sepsis, again working and managing a complex specialty team. We see a lot of procedures and we do a lot of catheters in. Most of them are post-chemo, post-neoadjuvant, and then they come to us. They have got a set of catheters in, they have got a bit of an immunocompromise in also. So they are likely to spike, and again, when too many lines on, the best possible advice I will always go in is take it off if possible, or replace it as early as possible. This is a simple advice I will tell. I'm not going to the complexities, but I would try to take off as early as possible. And I will come to certain special scenarios regarding the drains in a while. Now, urinary sepsis, nothing to add to, or I have only less to add what to say than Dilip said. He has highlighted again. Candiduria is one thing which you should think about, because most of the urine cultures for bacteria in the early days comes out to be negative. Still, you cannot say patient has got a urinary sepsis. So, urinary sepsis indeed has to be thought of, especially in long-standing catheterized patients, and especially malignant patients who is on medications for a long time, or compromised patients who should think about urinary sepsis. Now, I'm going to special cases. I'm sorry there is an overlap because it was an animation. There are 4 conditions which I always think about when I operate. One is trauma. Second is when you use prosthesis. The one on the left is when we had a splenic trauma being covered with a prosthesis. Third is when you do a biliary anastomosis. Fourth is when you do a pancreatic anastomosis. That means when you do deep-seated abdominal surgeries. I call it as a deep abdominal surgeries. So these patients, when they spike, never stay idle or never sit idle, because they are likely to have a deep-seated infection. You need to probe it. Okay, you need to probe it deep to find out it and then act accordingly. How to prevent a deep-seated collection, I always advocate, or we always advocate on the surgical side, senior side, that rather than the drainage system we use closed low suction drainage system like a JP drains, which are contained, because I work in a government college, and I worked in all the 3 setups, both abroad, both in corporate setup and government setup, and I know the hygienic situations in the ward, and it has improved dramatically in the last 10 years in the government hospital. Still, there is something lacking. So it is always better to have a closed drainage system, and the worry is when you're in the abdomen, you cannot use suction drains, but this is an answer for surgeons budding to use these drains, because that will definitely, and there is a study going on in our institution as well on this regard, to use of JP drains compared to the other drains in reducing the deep-seated collections and their outcome. So that is one thing which we can think about. And always think about the non-infectious causes. Non-infectious causes are important because non-infectious causes have to be there in your back of mind when you try to investigate on the surgical side, and also the drugs. Why drugs? Because I have seen drugs being used, medications being used in and out in post-operative ICU. Maybe some of them are new drugs. We don't know their effects, not like the conventional hypothermic syndromes, but there are drugs which can cause low-grade pyrexia, and that may confuse a surgeon, confuse a critical care, I will not say critical care specialist, but confuse a specialist. I just would like to go to this point, the surgical site infection. I always say it is actually a surgical wound failure. And the only person, there is nobody else. We can compound it due to various factors like immunity, type of surgery. You can say there are 100 causes, diabetes, uremia, everything can cause surgical site infection. But I, as a surgeon, I feel that if a surgical wound is infected, whether the rate of infection is 40% on a dirty wound to 4% on a clean wound, the sole responsible person is the surgeon, and surgeon is the best predictor for SSI. Because we have seen our great teachers operating. I have seen my professors operating. I've seen Burmas are operating. I've seen Dattans are operating. And that time, we can't say the microbial flora was not there in the ward. It was there in the ward. But still, the surgical infection rates are less. So there is some sort of a tissue discipline also the surgeons has to follow. And I always advocate my seniors, my team, to have a proper wound irrigation. Whatever be the nature of the wound, have a proper wound irrigation. And we did a study, a study, and we published it also on using of a pulse jet irrigation before closure, where we use a 50 Pascal pulse jet irrigation before the surgical site closure, wound closure in laparotomy wounds, which reduce the infection rate from 17 to 9%. So it's a simple technique, but definitely it has got an advantage because you yourself are causing the problem of infection. So basically, those are the conditions which we commonly come across. But we should never forget about the conditions which we can get when it is, which is quite little bit unusual. But think about the conditions like pseudomembranous colitis, acalculous cholecystitis, especially when you do long-standing or long-duration surgeries, and necrotizing fasciitis. That is coming up in a big way with infectious organisms like Clostridia, Difficile. I didn't have a personal experience with many of them, but still it is described and it is coming up. As a surgeon, I always see I will try to rule it out. So assessment and management has to be based on the concepts which we have learned, and we should know what to look for. So the moment the postoperative patient spikes, then you should go back to the basics. You should not jump into a plethora of investigations. You should have a proper history back in, look at the files, look at the operative time, look at the operative surgeon, look at the operative duration, look what procedure is done, what spillage has happened, and then take it from there. A good physical examination is a must before you order focused investigations in a postoperative pyretic patient. Again, I create a lot of mnemonics, and again I say an ABCDE for postoperative pyrexia. Whatever investigations you order, even though we say that we should overshoot, whatever investigation we should order in a structured way, which has to be apt, bold, clear, detailed, and elaborate, so that by the time you finish your investigation, you have a diagnosis and plan in mind. Dilip has already highlighted this point about the role of urine cultures and blood cultures. I'm not going to the details. In early postoperative days, the roles are limited, and you need not even wait for the cultures, because cultures may not stand positive even in an acute anastomotic disruption. You need to act before the cultures come in. That is what I want to say. And coming to imaging, we again use a lot of gadgetry images. Like right from chest X-rays, which is mandatory most of the time, and ruling out the deep vein thrombosis by Dopplers. Between ultrasound and a CT, I may be raising a controversial point, but I would like to raise it. Between ultrasound and a CT, in a patient you are suspecting a collection, I would rather say that if the CT is available, it is available in most of the centers, you need to think about going with a CT. Because definitely a CT will give you a 64 slice CT or a 16 slice, even a 16 slice CT will give you exactly the collection, what is the nature, what is the cause of problem. It can locate the problem and it will guide a surgeon whether to go in or not. It is not just aspirating the collection or draining the collection, because you by just one investigation you can decide whether to go in or whether you can hang on and put in a drainage. So I would rather say that when you are going for imaging, go with the best bullet you have and then take it further from there. So that is what I would like to say. And just to add on to the summaries of my approach or the algorithmic approach of post-operative fever, as we all started off saying that remove or replace the sources of infection, even if it is a catheter. Antibiotic policy we are going to discuss in detail, so I'm not going to the detail about that. But on the surgical perspective, I would like to say anticoagulation. Whenever you are doing a major procedure, definitely which is done most of the centers, so there is no need to re-emphasize on that. But when you have a PE, act fast and act promptly. And CT-guided drainage of abscesses, if there is no obvious leak and it's only collection, rather than having it remain, even if it is a 4 into 4 centimeter collection, it is better to take it off as early as possible. So every unit or every team has got their own protocol, and every unit should have a protocol. And we have a team of 17, and we have a definite protocol when we have a patient operated for X condition or a Y condition or a Z condition. And I'm little, I will rather say I'm a little overwhelming to show that is followed. Right, because that helps. I may not say that I am following the standard protocol which is followed all around the world, but I have trimmed it, I have taken into a cup which I can do in my hospital. Right, I can do in my hospital, and every team has to approach post-operative pyrexia in that context. And it is always better to know the sevens as a guide, because that is just a guide. You have to think and learn which is going to kill the patient, and also we have to think, did we cause it? And if we cause it, act fast. And also you need to go with the targeted labs and targeted investigation rather than ordering a battery of investigations. So my concluding remarks is, all fevers in the post-operative fevers are not obnoxious, they are not worrisome. But fever is a clue for you to act fast and to probe fast. Early fevers are mostly non-infectious, but 20% are due to dangerous conditions. Delayed fevers, I as a surgeon, I am relaxed because I am sure my team or my multidisciplinary team, which is available to me in form of physicians and the critical care specialists, will find it out and we can act. Early wean off from ventilators and early, that is one principle which I always follow and I always fight for, and focused approach. And I always advise my team to be a sniper rather than a shotgun expert, because you need to fire at the target as a sniper. Maybe, as Dilip said, it may be a multifactorial, so you can shoot 2 bullets rather than 1. Thank you very much for the patient listening.
So sir has covered almost all parts of the post-op fever, and that's from the surgeon's perspective. From the clinician perspective, from the ID perspective, we are not worried about post-transplant infections we can handle. But the post-op fever is where we get confused, whether it is infective, specifically the early post-op period. That's more crucial, because we always tend to say that it is non-infective, but you have to have your eagle eyes to pick out the wrong markers like thrombocytopenia, worsening sensorium. So some factors we have to look into and identify that early is very important. So thank you, sir, for that wonderful presentation. We will have a discussion later. Thank you.
So regarding that case, actually he was a 43-year-old male, presented with, as already not 1 month fever, cough, and he presented in shock, and he had a left massive upper lobe consolidation. So what happened actually was, after admission, 3 days later, he developed pain and swelling in the right angle, and he developed a right angle joint arthritis. So that was a change in the picture. By that time, sputum culture was done negative, gave it as a contaminant sample of Pseudomonas, and that was discarded, unfortunately. And From that angle joint aspirate, a pus culture, aspirate was sent for culture, and that turned out to be melioidosis. So that was the case. It was a case of melioidosis. And remember that actually he was working as a crane operator in an area in Malappuram where there was flooding, landslides 3 years back. So possibly it's a soil pathogen. So that gave the name Vietnam time bomb, where the soldiers were exposed at that time initially, and they later developed this catastrophic illness few years later. So that was a case of melioidosis masquerading like something looking like tuberculosis or malignancy. Okay. I move to the third case. I will just bring this thing. You can observe a lot by watching. Actually, all these slides are inspirations from Rajalakshmi ma'am, because I usually hear her classes to SITS. So actually a close fan. So actually this was a 46-year-old female while was working in Calicut. She was from Nepal. She presented with 3 weeks fever, fatigue, headache, and arthralgia. And he had more than 2-week fever. And CVA showed a short systolic murmur at the apex. So you can see the counts. Total count was 18,900. Polymorph predominant, high ESR, and high platelet 3.3 lakhs, and urine showed microscopic hematuria. And someone had suspected the possibility of endocarditis, and a transthoracic echo was done from outside, which turned was normal. And usual workup was done, everything turned out to be negative. And in the course, she was prescribed on antibiotic, and in the ward, she developed confusion, headache, and positive movements on right half of the body. And CT was reported as multiple infarcts. And when we proceeded with MRI, it showed multiple abscesses in the brain. While during the rounds, we noticed these subtle signs over the digit. This was a turning point. We re-evaluated the possibility. These were the skin lesions during rounds. So, what is this clinical finding? What is a likely diagnosis, and what next? And Occam's razor is develop a unifying diagnosis to explain all the things we have seen.